Hello, welcome to Atropia Medical School. Today we are going over 5 EMT questions on chronic obstructive pulmonary disease, also known as COPD. If you like the content, like and subscribe. Let's get started. First question, which of the following is not a common sign or symptom of COPD? A, barrel chest, B, pursed breathing, C, pulmonary edema, or D, prolonged exhalation. Take a moment to think about the answer. And if you picked pulmonary edema, you are correct. Pulmonary edema is more associated with congestive heart failure, or CHF, where there's more intrinsically a issue, particularly with the left ventricle pumping blood forward. And so it just backs up into the lungs. Eventually it starts leaking into the alveoli, the water or serous component of the blood. And that's why you hear rales on auscultation with someone with CHF. Now, COPD in many ways overlaps with asthma, chronic obstructive pulmonary disease. What's going on here? So what's happening is over time we have some, we'll call them maladaptations due to certain respiratory things going on. So there are two types of COPD. You have chronic bronchitis, and you have emphysema. And in both of these cases, because we over time have developed a chronic issue with trying to get air out of the lungs, just like in asthma, the issue is not simply I can't get air into the lungs, because we can get air into the lungs. When we breathe in, it's an active process. When we exhale, it's normally a passive process. And now we're trying to force air out of our lungs, and it's become harder. Why? Well, in chronic bronchitis, that makes sense. The bronchi are chronically inflamed. Smaller pipes, it's going to be harder to breathe out. Emphysema, it's more of an issue with the alveoli. So normal alveoli should be, look kind of like grape-like sacs or clusters of grapes. This is where all of your oxygen and CO2 exchange happens because there's lots of little capillaries around all the alveoli. But in emphysema, the alveoli become super blown out and distended. They kind of lose their shape. They're more balloon-like rather than, grape-like clusters. They don't hold their shape very well. So on the one hand, they can hold a lot more air. Because they're super dilated out. They can hold a lot more stuff compared to your normal alveoli. However, they don't hold their shape very well. So they just kind of like deflate like a balloon when we exhale. So we can actually lose everything in the alveoli and actually develop atelectasis. And that's one of the big issues with your emphysema patients is they're going to have a hard time fully exhaling out because of this. Whereas in chronic bronchitis, they're having a difficult time exhaling out because they're trying to exhale out against chronically inflamed bronchi and bronchioles. As a result, you're going to see prolonged exhalation, kind of like what we see with asthma. Pursed breathing, that helps build back pressure. I'll write that down here. This is a way of generating back pressure on the respiratory tract in order to keep more stuff in the alveoli. And that way they don't fully deflate and we get atelectasis. Barrel chest is an adaptation we oftentimes see. If I'm having a hard time forcing stuff out, guess what? My chest muscles and my chest wall is going to start building up and out in order to not just hold more stuff, but to generate enough pressure to kind of force things out. It's interesting that we see both the pursed breathing and the barrel chest happen in a lot of these patients, right? We're keeping that back pressure while at the same time building up those muscles. But that is, oftentimes we see elements of both things going on in the same patient. All right, next question. Which of the following is the most accurate description of the pathology behind emphysema? A, dilation of the alveoli. B, environmental trigger causing an acute bronchoconstriction. C, multi-system allergic reaction. Or D, air bubbles outside of the pulmonary tissue. So take a moment. And if we picked A, you're correct. We talked about this in the previous question. Emphysema is not so much an issue per se with the bronchi. It's an issue with the alveoli dilating out, becoming super floppy. Yes, they can hold more air. So we'll make a note of that here. They can hold more air, but they also tend to go into atelectasis pretty quickly. Atelectasis. Meaning that they lose their shape, they collapse in on themselves, and it's harder to get them to open up back again. Now, B is describing anaphylaxis, or a systemic multi-system allergic reaction. I'm sorry, wow. I meant to cross that for C. Look at me not paying attention. That's for C. B is talking more about asthma. And then D, I just wanted to go over this here kind of quickly. D is describing something called subcutaneous emphysema, which is different from just regular old emphysema. And what this is air bubbles underneath the skin or in tissues. This can happen for a number of reasons. It can happen in a tension pneumothorax or pneumothorax situation. The air starts percolating through the tissues over time, and we may feel this as Rice Krispie treats under the skin. We can see this in tracheal lacerations, so this can happen there too. And we could see it in perforations as well, of like the GI tract, the stomach, the esophagus, things like that. All right, let's move on. A patient with chronic bronchitis will commonly present with which of the following? A, pulmonary edema. B, distended abdomen and cyanosis. C, tracheal deviation. Or D, stridor. Take a moment. And B here is the correct answer. This one's a little bit trickier. Why would we see a distended abdomen and cyanosis in chronic bronchitis? Well, any patient with respiratory difficulties may over time become cyanotic due to hypoxia. So when we see in a test question cyanosis being thrown into the mix, we should think there may be an element of hypoxia going on. Now, there's all sorts of reasons why the hypoxia is going on. It could be an oxygenation issue, could be a vascular issue, it could be, a few things, right? It's not just simply, they can't breathe, right? That's not the only thing. But it should be something we consider. Excuse me. Now, distended abdomen, the reason why this happens, and to go into little physiology here about COPD, in particular chronic bronchitis, is imagine that your bronchi are chronically inflamed. Chronically inflamed bronchi. Well, your bronchi have they are surrounded by blood vessels. They're surrounded by the various pulmonary arteries that are going, towards all your alveoli. When we have chronically inflamed bronchi, this also will cause structural changes to the blood vessels. They have to now kind of handle more work, if you will. And so what happens over time is we develop something called pulmonary hypertension. We know hypertension, high blood pressure, same thing can happen in the lungs. The pulmonary blood vessels can start having more and more pressure build up in them. Now, why is this important to note? Because over time, this is going to stress out the right side of the heart. We'll just say right ventricle. So the right ventricle is not a high pressure pump, if you will. We know the left ventricle does a lot of work to pump blood systemically, but the right ventricle just has to pump to the lungs. Imagine a relatively low pressure system becomes a high pressure system. Initially, the right ventricle will hypertrophy, meaning it's going to try to build itself up. It may even dilate out over time too as it gets more and more stressed out, and eventually it's just not going to be able to pump very effectively. And so this eventually leads to failure, right? So we get right ventricular failure. We see some similar stuff with CHF, where initially the left side of the heart starts not working right, and that leads to the right side of the heart not working right because it's trying to pump it's trying to pump more blood to already filled up blood vessels in the lungs. And so that blood backs up into things like JVD. And we see that pop up as JVD. We see some of that peripheral edema form because everything's backing up in venous circulation. You have a lot of venous circulation in your abdomen around your GI tract. So we're going to back up a lot of blood there. And so we see it as kind of abdominal distension. And you'll oftentimes see your chronic bronchitis patients described as blue bloaters as a result. You've probably seen charts in your textbook or online somewhere calling your chronic bronchitis patients blue bloaters. In contrast, you might have seen your emphysema patients called, and why don't we zoom back? Why don't we zoom back here? You've probably seen your your emphysema patients referred to as pink puffers. Because these patients tend to be less cyanotic because they're actually holding on to more air in their alveoli, but because they have the pursed lip breathing, the big barrel chests, they're oftentimes colloquially called pink puffers. Nice. All right. So, just to kind of summarize things that we just talked about, chronic bronchitis, blue bloaters, chronic inflammation of the bronchi will lead to pulmonary hypertension, so high blood pressure in the blood vessels of the lungs, and eventually that's going to stress out the right heart, the right ventricle in particular, to the point where it just goes into failure, and that blood starts backing up more and more into venous circulation. Whereas in emphysema, dilated alveoli, pink puffers, they usually can oxygenate a little bit better. But on the flip side, they hold on to a lot of that air. Their alveoli dilate out even more, and they can't fully exhale because if they do, they're going to collapse in all of those now stretched out alveoli. All right, next question. You give high flow O2 to a COPD patient, and note they go into respiratory depression. Why would this have occurred? A, oxygen toxicity. B, overactive carbonic drive. C, an airway obstruction occurred. Or D, their hypoxic drive was suppressed by high flow O2. So let's take a moment to think about the answer. And if we picked D, you are correct. Awesome. This is not to say oxygen toxicity isn't a thing. It absolutely is a thing. Hyperoxygenating people for long periods of time is not good if they don't need that O2 because it just sits around in the bloodstream. And oxygen is highly reactive and it will start reacting with stuff. But that's not the issue here. Overactive carbonic drive, this is the exact opposite of COPD patients. They actually have an underactive carbonic drive. We'll talk about that in a second. There's no indication of stridor, muffled voice, or anything that we've talked about previously that indicates an airway obstruction. I'm not too worried about that. But why hypoxic drive being suppressed? So let's talk about normal people here. So normal people, you or I, hopefully you're a normal person, we have carbonic drive. What is carbonic drive? Carbonic drive is where we breathe off of CO2 levels. Breathe off of CO2 levels. So our body is very sensitive to acid-base balance. And normally it's between 7.35 and 7.45 in terms of a pH. And your body wants to keep it that way. Let's say you're running a race. Whenever we're doing a lot of work, we're generating a lot of CO2, we're generating a lot of acid. Our body is sensitive to that. And what's the easiest way to get rid of that acid? Just breathe it off. Remember, we exhale out CO2. So I breathe faster, I breathe deeper, I get rid of that CO2. That is carbonic drive. And then when I stop running the race, my respiratory rate goes down. I breathe with a little bit less force. Why? Because I'm no longer generating that much carbon dioxide. I'm not generating that much acid. I don't need to breathe off as much of it. And I can keep the acid-base balance where it's supposed to be. Now, COPD patients are a little bit different because they can't usually fully exhale. They can't get rid of all that CO2. Their carbonic drive becomes very insensitive. And this is not to say that they don't have a carbonic drive. Every patient's a little bit different. But it's no longer going to be as fine-tuned because their body is now getting used to having high CO2 levels in the blood. It's just we get used to things over time. Whether or not that's a good thing is a whole other story, but we will get used to not being able to use carbonic drive as effectively. However, we do have a backup. It's called hypoxic drive. You do have pressure baroreceptors in your brain and in your blood vessels that detect how much what we call partial pressure of O2 there is. But the problem with this is that with hypoxic drive, it's more like an on-off switch. It's not, whereas carbonic drive is more like a dial, right? I can dial it up, I can dial it back. But with hypoxic drive, it either really kicks in or it really kicks off. And that's kind of an oversimplistic way of looking at it, but that's how we need to think about this for the test. Anyways, with a COPD patient, they oftentimes live, in the 80s, 80% to 90% range. That is kind of normal for them for an SpO2. And so if they're really at that low end, their hypoxic drive may very well kick in. And so they start breathing and breathing and breathing, and then they get up, to a reasonable level and it kicks off. And so they sometimes can bounce back and forth. And so this is why when we get their O2 sat up to like 99% on high flow O2 and we keep them there for a bit, that's going to tell their body, hey, you know what? We got plenty of O2. We don't need to breathe anymore. And so they go into respiratory depression as a result, or can. So keep in mind, when you have a COPD patient, if you can keep them in that like 90 to 94% range, that's good enough. We don't need to hyperoxygenate them. We don't need to get them up to 99%. This is pretty ideal, right? Again, a lot of times these patients live in that 80s, and that's fine for them. But if they're having issues, if we get them to 90 to 94%, we're good. We don't need to go beyond that. Nice. Excuse me. One more question. You have a 60-year-old with a history of COPD complaining of shortness of breath. You notice bilateral wheezing, rhonchi, as well as peripheral cyanosis. The vital signs are heart rate is 90, BP 140/80, respiratory rate 24 and labored. Respiratory rate was 24 and labored. SpO2, 82% on non-rebreather mask. Which of the following interventions could you use to help this patient? A, albuterol. B, CPAP. C, call for ALS. Or D, all of the above. Take a moment. I feel like this one isn't too bad. All of the above. Why? So we notice that they have wheezing. Wheezing is one of our big indications of bronchoconstriction. How can we solve bronchoconstriction? We can give them albuterol. Works quite nicely. We've talked about previously, CPAP is a fantastic tool for anyone with severe respiratory distress. And note how they're, 82% on non-rebreather mask. And I know these patients tend to live at lower O2 sats. I get that. But they're clearly still symptomatic, right? They mentioned elsewhere they're still labored, right? So maybe we need to help them out a little bit more. Let's give them the next step up. So we can do the albuterol. We can certainly throw in the CPAP. There's nothing here telling us we cannot, so maybe worth considering. And call for ALS. I know we sometimes poo-poo the call for ALS as kind of like a cop-out answer, but I've got two good answers here, right? A is a good answer, B is a good answer. At this point, it seems pretty reasonable. Yeah, let's call for ALS. There's things as an ALS provider I can do. For example, there's certain other medications like ipratropium bromide. We could do an epinephrine IM injection to force bronchodilation. We can give them a smooth muscle relaxer like magnesium sulfate. We can give them steroids. There's a bunch of stuff we can do. So all of the above is pretty reasonable. Now, again, we do want to keep in mind these patients, have hypoxic drive going on more than likely. So we don't want to over oxygenate them. That's, something you'll have to monitor over, the transport time. But again, we're not going to withhold interventions that people can potentially benefit from. We just monitor them. Anyways, I hope you found this helpful, better understanding COPD and how we treat it. If you like the content, like and subscribe. If there's other things you want to see, absolutely send a comment our way, and we'll see you next time.